All right, good morning, everybody. I'm here to give a research update on this very, very long IUPAC name in maintenance tocolysis. So this, I'm not even going to try to pronounce it, but this is actually the IUPAC name for Procardia. So we're going to discuss today Procardia and maintenance tocolysis. And the reason why I put up this long IUPAC name is just so we remember that the medications, we tend to think about them just in our brand names or our generics and what have you, and they're really much more complicated than that. And that's why we can all remind ourselves of that. So when I was first going through thinking about what to talk about, and I was thinking of this topic, I didn't really have any patient to discuss. And then some patient, I don't know, knew that I was looking for a patient to discuss, and she came into clinic last week. And this is her presentation. So she's a 21-year-old G2P0010. She's at 27 weeks and 4 days, and she has cramping. And she came in, this was actually to the WIU, and she was 390 with a bulging bag, and she received 48 hours of tocolysis with magnesium sulfate as well as betamethasone. And they did a transvaginal ultrasound, and the cervical length was 0.5 centimeters with V-shaped funneling identified. And after the magnesium sulfate and betamethasone, once she had entered the quiescent stage, she received Procardia 20 milligrams POQ 4 hours for maintenance tocolysis. Hospital day number 11, a repeat transvaginal ultrasound was done, which again revealed funneling down to the level of the external os with dynamic changes from a U-shaped funnel to a wide V-shaped funnel, 3.3 centimeters at the level of the internal os. On hospital day number 17, she reached 30 weeks. She was discharged on maintenance Procardia for maintenance tocolysis. So 10 days later, she comes to the clinic. She's now 31 weeks and 3 days, and she states that she stopped the Procardia because of decreased fetal movement. And when she stopped the Procardia, lo and behold, the baby started to move once again. She was feeling contractions that were non-painful. She was a 300 bulging bag. We did an NST. There were no contractions noted. Repeat exam was the same, and so she was sent home with labor precautions. And then 2 days later, she came back to the WIU complaining of painful contractions, and she was contracting about every 5 to 7 minutes. And they restarted magnesium sulfate and a rescue dose of steroids were given. Second. So just before we discuss the literature, just a brief review of calcium physiology. So the free calcium concentration in the cytoplasm at rest is maintained about 100 nanomoles per liter. And the calcium concentration in the interstitial fluid is about 12,000 times the concentration in the cytoplasm. So therefore, there's a marked inwardly directed concentration gradient as well as a inwardly directed electrical gradient. Much of the intracellular calcium is stored at relatively high concentrations in the endoplasmic reticulum and other organelles. So you have a gradient both from the interstitial fluid into the cytoplasm as well as from the organelles inside the cell into the cytoplasm. And this is just a cartoon. So you can see here's the interstitial fluid over there. Here's the mitochondrion and endoplasmic reticulum. And there is a calcium gradient into the cytoplasm of the cell. So, remember about troponin, which is involved in the contraction of skeletal muscle or cardiac muscle. So there's a similar protein called calmodulin that's involved in smooth muscle cell contraction. And calmodulin is capable of activating 5 different calmodulin-dependent kinases amongst other proteins. And one of these kinases is myosin light chain kinase, which phosphorylates myosin. So once myosin is phosphorylated, a cross bridge is formed, and the myosin binds to actin filaments, which brings about contraction into the smooth muscle. So here you can just see here's the calmodulin, which is the protein that binds to the calcium, It activates myosin kinase. Myosin kinase is phosphorylated, and there's something called, once it's phosphorylated, it's called PL-myosin, which allows the myosin and actin cross bridges to form. Once this is a cycle, and as phosphatase also binds to this PL-myosin, then there's something called L-myosin, which inhibits myosin-actin interaction, and it's a cycle. Obviously, this is not under voluntary control. We cannot tell our patients specifically when to contract the uterus and when not to contract, although that would be sometimes helpful. So that's the physiology of calcium. So now we're going to go a little bit to Procardia. Procardia is a type 2, which is a dihydropyridine calcium channel blocker, and it actually plugs the calcium channel in this open or closed state. You can see this is a very big, bulky molecule, comparatively speaking. And it's metabolized mainly in the intestinal wall. A small component is metabolized in the liver. Most of it is excreted in the urine, and the remainder is removed with feces. And the onset of oral nifedipine is about 20 minutes, and the half-life of oral tablets is about 1.3 hours. And when you give XL, the half-life is about 15 hours. So I'm going to discuss 4 articles that discuss maintenance oral nifedipine. This one is from 1999, and so that's why it's a little bit difficult to read. But I'm going to read the abstract. So this was published in AJOG in 1999 from our next door neighbors in Louisville, Kentucky. And what they wanted to do is evaluate the efficacy of maintenance oral nifedipine in patients initially treated with magnesium sulfate for preterm labor. So they took patients with a diagnosis of preterm labor between 24 and 34 weeks, and they were randomly assigned to receive either the nifedipine or a placebo, or no treatment. And then pregnancy and neonatal outcomes were evaluated, and according to their statistical analysis, you needed 50 patients to detect a 10-day difference in the meantime gains. They actually got 74 patients, so they definitely met their power analysis. 37 received oral nifedipine, and 37 received no treatment. The delivery gestational age was 35.4 plus or minus 3.2 weeks for patients randomly assigned to receive nifedipine, and 35.3 plus or minus 3.2 weeks for patients who received no treatment. The time gained during pregnancy, there was a difference in 5 days. So just to go through this a little bit more, this was a prospective randomized trial. So this is going forward. It's going forward from patients who were actively admitted, and it's not a retrospective chart review. They recruited 74 patients between 24 and 34 weeks who received IV magnesium sulfate. The inclusion criteria, and I bring this up because the inclusion and exclusion criteria were a little bit different in all the different studies. In this study, the inclusion criteria were greater than or at least equal to 6 contractions per hour for at least 2 hours, cervical dilation of 2 to 4 centimeters, more than 75% effacement, or evidence of cervical change. The exclusion criteria was cervical dilation that was greater than or equal to 5 centimeters. If there was obstetric contraindications to cervicalysis, for example, chorea amnionitis, lethal fetal anomaly, significant antepartum hemorrhage, or maternal or cardiac or liver disease. So these patients were in preterm labor, and they were treated with magnesium sulfate, the same we do over here, and then they were randomized to nifedipine maintenance therapy, which was 20 mg PLQ 6 hours, or observation. And this was computer-generated random number tables were used for assignment, and the group assignments were placed in sealed, opaque, sequentially numbered envelopes, which is what same thing we're doing the Alexis study upstairs. So patients were observed for 24 to 48 hours before they were discharged home. If the contractions increased, then the interval between the nifedipine doses would decrease, the same way we do over here. If preterm labor resumed, then again the patients were treated with mag sulfate or TERB, and were treated as per the group that they were already assigned, and the nifedipine was stopped at 37 weeks gestation. So, I don't know if you guys see in the back? So here's the control groups, and here the patients who received nifedipine. The delivery gestational age is here in the control group is 35.3 weeks, and in the nifedipine group is 35.4 weeks with a statistical significance of 0.9. Remember, usually in the health sciences, we say something is statistically significant if it's if a p-value of 0.05 or less. So you can see this is really 0.9, so there's no statistical significance over here. The delivery prolongation, mean number of days, was 32.8 for the control and 37 for the nifedipine. So there was a 5-day gain. The reason why they did this is because people were enrolled at different gestational ages. So it's a little, it's not fair just to look at the delivery gestational age. You want to see how much time was gained by being on the nifedipine compared to the control. And that was a difference of about 4.5 days. The significance value over here is 0.4. Again, not statistically significant. In terms of not everybody necessarily complied with the protocol. For those people who complied to the letter of the law, the gestational age for the controls was 36.1, and for the nifedipine was 36.1 as well. And the pregnancy prolongation for the controls was 36.8 days plus or minus 18.9 days, and the nifedipine was 41.9 plus or minus 22 days. So here again, you're approaching getting a little closer to 0.05, but really not statistically significant. What about neonatal outcomes, right? Why do we try to prolong gestation? We try to do it for the sake of the baby. So in terms of birth weight, the average birth weight was, for the controls was 2496 grams plus or minus 705, and for the nifedipine was off by a gram. It's pretty close. The arterial and venous cord pHs are, again, very, very similar with p-values of 0.2 and 0.8.
In the previous slide, was the data adjusted for parity?
I don't know. This data was not adjusted for parity. I don't think it was. Potentially, yeah. But it's because people were multiparous would presumably, have a tendency to go quicker. It could.
Even the smaller numbers, look at the NICU admissions on both sides. More admissions than that English.
You do. We'll get there. This was 15 years ago.
And did they measure the calcium cord loss?
No. None of these studies measured calcium cord loss.
So they don't know why they went to NICU.
Why the patients went to NICU specifically? They just know they just went using specific they picked specific neonatal outcomes as a secondary analysis. And this is what specifically that they looked for. Why did they stay so long? Presumably it would be for the gestational age at delivery. That's what I'm guessing.
Blood pressures on the baby?
They didn't measure blood pressures on the babies. None of these studies measured blood pressures on the babies. 37 weeks for this study. Well, that's a whole nother question. It's a small number, also, Yeah. I don't know why they picked 10 days. I don't know why they specifically picked 10 days. Made it easier. Yeah. Yeah. I don't know. So this actually was the only study that looked at the side effects of nifedipine. From these patients, there were 37 patients who received the nifedipine. There was 1 case of headache, 3 cases of fatigue, 2 cases of flushing, and 1 case of an allergic rash. So we see that it's like 7 out of the 37 in this study had some sort of a side effect. The limitations that they quote of the study are that it's not a double-blind, placebo-controlled trial. They have a frequent tocolysis regimen, which means that they took the nifedipine every 4 hours as maintenance tocolysis, and there's difficulty in accurately diagnosing preterm labor on the basis of clinical findings, which is a problem, quote unquote, in all the studies because it's all clinical diagnosis. So their conclusion was that maintenance tocolytic therapy with oral nifedipine did not significantly prolong significantly prolong the pregnancy, but again, as they use some reason a 10-day difference in pregnancy prolongation. So that's study number 1. So in 5 years later, a group from Japan decided to also look at oral nifedipine maintenance therapy after acute intravenous tocolysis in preterm labor. And this too was a prospective. I'm sorry, in Turkey. Did I say Turkey? Oh, sorry, I meant Turkey. Yeah, Turkey. So I said I meant Tokyo. Turkey. All connected, all close. Anyway, yeah, Turkey. So they did a prospective randomized trial with 73 patients with preterm labor as well. So their inclusion criteria was regular uterine contractions of over 4 per hour with documented cervical changes on serial digital exams. You required intact fetal membranes, and they could not recruit them if they had any medical or obstetrical condition that required delivery. Their exclusion criteria was more than 4 centimeters, which is different than the other study. They excluded triple or higher order pregnancies. They, too, like the first study, excluded documented uterine infection and fetal congenital anomalies. They excluded, over here, fetal growth restriction, and any contraindication to beta mimetics, such as diabetes, cardiac disease, or hyperthyroidism. And their primary outcome, again, was the time gained from initiation of maintenance therapy to delivery. And the secondary outcome measures were the gestational age at delivery, perinatal outcome, and recurrence of preterm labor episodes. I believe it was type. Actually, I think it was everything. I think it was type 1 too. So they were initially on batteries. They received IV saline therapy, interesting, before starting acute tocolysis, and they were assessed hourly for contraction frequency and cervical dilation and effacement. And they were treated with the IV infusion of ritadrine and Verapamil until uterine quiescence was achieved. So ritadrine was a beta mimetic, somewhat similar to TERB. And the reason why they gave the Verapamil was because cardiovascular side effects were less common in patients who were receiving the beta mimetic therapy when the Verapamil was added. So this Verapamil was added in order to decrease the side effects from the beta mimetic. So after the uterine quiescence was achieved, the patients were randomly assigned to receive nifedipine maintenance therapy or no therapy. The tocolysis with nifedipine was initiated 2 hours before discontinuation of IV therapy, with oral doses of 20 milligrams given every 6 hours. So there was a little bit of an overlap of the ritadrine and Verapamil with the nifedipine by about 2 hours. And once on the medication, placebo for 24 hours, with no signs or symptoms of preterm labor, the patient was sent home and seen weekly in the clinic. If the preterm labor episodes recurred, then oral maintenance therapy was accepted as unsuccessful and discontinued. And the patients were subsequently retreated with IV therapy, and oral maintenance therapy was reinitiated after successful repeat IV tocolysis was completed, and the patients were managed according to the same protocol as in the first admission, so similar to the first study. The therapy was discontinued if membranes ruptured or if 37 weeks of gestational age was reached, and patients who were assigned to no therapy were treated with IV tocolysis in cases of readmission for recurrent preterm labor. And after successful therapy, they were discharged home without being given maintenance therapy. So the people were maintained in the same groups that they were assigned to initially. So here you can see the gestational age at admission was about 32.3 versus 31 weeks. The gestational age at delivery, according to those who had the maintenance therapy, was 37 weeks, and those who had no treatment was 35.1 weeks. And their p-value here is 0.003. So this is much lower than 0.05, so there is statistical significance over here. And the time gained to delivery for those who were on the maintenance therapy was about 27 days, and those who were on no treatment was about 16 days. And here you have a clinical significance of 0.07. In terms of the birth weights, they were very similar. The admission to the NICU was the same. The number of days in the NICU here was much, much lower than in the first study. And here they have 1.5 days and 1.9 days, plus or minus. So their limitations was that there was a small sample size. The nifedipine was not used for acute tocolysis. It wasn't randomized against a placebo. The methods of randomization in this study are not described for some reason. and they did not do an amniocentesis to examine the cervical secretions to rule out intra-amniotic infection. So their conclusion is that nifedipine maintenance therapy for preterm labor after IV tocolysis was effective in terms of prolonging the time interval to delivery, but did not improve the perinatal outcome. So here you have one study that said, from 1999, that said that it improved it, and another study from 2004 that said it did not improve it, and then the question was, so what do you do? Granted, you have to take into consideration that the terms of the study were different. They were not exactly the same in terms of their inclusion and their exclusion criteria. So, fast forward 4 years, and Dr. Lyle's group and Dr. El-Sayad's group also did another study. They're looking at maintenance nifedipine tocolysis compared with a placebo. So this was a prospective randomized double-blinded study. It was multi-center. The inclusion criteria were between 24 and 34 weeks. The patients must have been in active labor, preterm labor as defined by contractions with cervical change, and the preterm labor had successfully been arrested with IV mag sulfate or oral nifedipine. And these people had to have 6 or fewer contractions per hour. They had to have intact membranes. The cervical dilation had to be less than 4, and the maternal age of at least 18 years. The exclusion criteria, again, were obstetrical indications, including placental abruption, placental previa fetal anomaly incompatible with life, triplet or higher order multiple pregnancies, documented intrauterine infection, or a maternal medical contraindication to ongoing tocolysis. The randomization was generated by a random numbers table. It was double-blinded. The pharmacies at both institutions maintained blinding, and they dispensed all the drugs. The patients received coated tablets of either 10 mg of nifedipine or an identical placebo. They were instructed to take 2 tablets orally every 6 hours, so they were taking 20 mg every 6 hours. And if patients were discharged home, they continued their study drug on an outpatient basis. The treating physicians could change the dosing interval of the study drug to every 4 hours, depending upon patient's symptoms. And here, 2 patients who experienced recurrent preterm labor before 34 weeks had maintenance tocolysis. Tocolysis with magnesium sulfate if the membranes were intact, and if they lacked maternal or fetal contraindications to the tocolysis. And if the recurrent preterm labor was arrested, then the patient was restarted on the originally randomized drug regimen, and treatment here was continued until 37 weeks gestation. Data was analyzed by the intent to treat. The primary outcome over here, again, was the achievement of 37 weeks of gestational age. The secondary outcomes included the mean gestation age at delivery, the mean delay of delivery, and the mean delivery of more than 48 hours at 1, 2, 3, and 4 weeks, birth weight, and neonatal morbidity. So here you have patients who were randomized for 71. 3 of them were not included in the analysis, and 68 were analyzed, 33 receiving the nifedipine and 35 receiving the placebo. Interestingly over here, the dilation at entry between the nifedipine and the placebo, patients with the placebo were farther along. So they had a dilation of 2.5 centimeters as opposed to 2 centimeters, and the cervical length was longer in the nifedipine group than in the placebo group. So it seems that the patients with the placebo are a little bit behind the 8 ball. And you have here a p-value of 0.02 and 0.03. So that's all statistically significant.
Did they quantify uterine activity at 150 units?
Oh, and no, nobody used montevideo units in any of these studies. So this is all they looked just at the frequency of the contractions and how often they were. Yeah. Correct. Yeah, that's correct. There's a p. Yeah, I mean, if you're going to be according to the p-value is 0.06, so it just reaches the statistical significance. Whether it's clinically significant or not. Right? There's always an argument whether something's statistically significant and not clinically significant, or vice versa, whether things are clinically significant and not statistically significant. But since I'm taking biostats now, I'm going according to that. No. So over here, if you look at at those patients who achieved 37 weeks, there were 13 patients in the nifedipine group and 13 patients in the placebo group. So there's a p-value of 0.91. The difference probably being, I don't know why it's not 1, to be honest. The delay,
Just one question. When they put together this study, did they say as to how many patients they needed
significant? They probably did, and I don't remember.
So that
Yeah, I don't remember what the actual number needed to treat the show power was. I have it in my. I don't think I have it in my. Yeah. I can look it up. I have it in my. I don't remember specifically. The delay.
that would be important.
Right. Yeah. How many patients are going to use? Their delay in delivery in the days from initiation of the regimen to the time of delivery, according to those patients who were in the nifedipine group, was 33.5 days and 32.6 in the placebo group, so like a p-value of 0.81. Those patients who delayed delivery by more than 48 hours were almost all of them, both in the nifedipine and the placebo group, with a p-value of 0.49. The gestational age at delivery with an nifedipine group was 35, and with the placebo group was 35.2. And so here you can see a Kaplan-Meier curve of those patients taking the nifedipine and those patients taking the placebo. You can see they're pretty much parallel and almost on top of each other. And the delay of delivery in terms of days is very, very similar, whether you're taking the nifedipine or whether you're taking the placebo. In terms of the neonatal outcomes, the birth weight was 2.3 kilo in the nifedipine group and 2.4 kilo in the placebo group. The low birth weights were similar. The days in the NICU were similar as well. So the limitations over here, is that they had a small sample size as well, and if there's a small benefit to nifedipine, then the study may not have detected it per se. The placebo group had more advanced cervical dilation, and there was also a large number of twins, like you mentioned before.
None of the studies need to break it down on whether they were spontaneous or indicated.
Right, correct.
And if you're looking at 37 weeks of twins, I would guess that some of those thought they were
Other reasons, yeah.
Well, they probably look at them and they got
They don't mention.
they randomized.
They did it by intent to treat.
that was the central group, and that was expected.
You know, they had 15 twins at 33 and they kept saying N 33. I don't think they did it. Because there were 33 in the placebo. They just say N. Some of those deliveries before they were in both groups had to be medicated. I think the average was 75 high-risk patients not medically to deliver at least a couple before 37
When
weeks.
they did it, then the state started using this.
We should state that data. We should state that.
Yeah.
Well, we're looking.
I hope. And finally, this past year, in January of 2013, so there's this group decided to look at the effective maintenance of glycolysis with nifedipine and threatened preterm labor, and they went to look at the perinatal outcome. So everybody else was looking. The primary outcome was how much gained was either the time of delivery or how many days were gained to delivery. And their thought process was, well, who cares? Because at the end of the day, you were worried about how the baby does. So let's look at how the babies did. This was a randomized, double-blinded placebo trial. It was multi-center in the Netherlands, like 11 centers. They called this the Apostle 2 trial, which stands for the Assessment of Perinatal Outcome, with sustained tocolysis in early labor 2. I do not know what 1 was. The inclusion criteria was gestational age between 26 and 32 weeks and 2 days, the diagnosis of threatened preterm birth. They were treated with tocolysis according to local protocol for 48 hours, and they completed a course of corticosteroids. The exclusion criteria, again, was signs of intrauterine infection, signs of fetal distress, fetal demise, placenta previa, maternal disease, maternal hypertension, or a contraindication for the use of nifedipine. Preterm labor definition included changes in cervical length, or progression in dilatation in combination with contractions or ruptured membranes. So here they included ruptured membranes, and other studies it was excluded. It included women either with singleton and multiple pregnancies, and also women without ruptured membrane. So this is different than some of the studies that I mentioned previously. So here, the preterm labor was stopped with nifedipine or ataciban according to the local custom, and then the women were randomly assigned to receive nifedipine 20 mg per day, which is like 20 Q6, or placebo for 10 days. The study medication was phased out from day 10 until day 12 and discontinued on day 13. The duration of medication was a maximum of 34 weeks gestational age. So if they reached 34 weeks, it would just stop the study.
What was the rationale for the PCV in the draft?
For spacing it out, I don't know. I think they wanted to make sure that I presume it would be that so that way there's no direct abruption, stopping the medication, then there's a rebound of something or other. So if you phase it out a little bit like steroids, I'm guessing. I don't know. I don't know. Yeah. So once the study medication was completed, a rescue course of steroids was allowed in cases of recurrent threatened preterm birth. The group assignment was based on a computer-generated random sequence, and the treatment assignments and block sites were blinded to investigators, clinicians, participants, and the research nurses. The primary outcome over here was neonatal morbidity and neonatal mortality, and these babies were followed up until 6 months of life. Neonatal morbidity included severe respiratory distress, bronchopulmonary dysplasia, intraventricular hemorrhage more than grade 2, paraventricular leukomalacia more than grade 1, sepsis, neck, or a low, and the birth weight. And the secondary outcomes included gestational age at delivery, the days on supported ventilation, the days on additional oxygen, the days in the NICU, the total days in hospital until 3 months corrected age, and the costs involved. So, over here you can see that there's 3 different groups. There's nifedipine, placebo, and they also included patients who were non-randomized, because about 200 patients declined participation in the study, and they wanted to make sure that these patients who declined were similar in nature to the patients who were in the study. And you can see that they're very close to each other. So here you have 636 patients assessed for eligibility, 230 declined to participate, and 406 were randomized. So in those patients who were randomized for nifedipine, 198 received the nifedipine and 3 withdrew from the study. 9 discontinued intervention. 3 needed emergency tocolysis, and 6 discontinued for other reasons. And 201 women were included in the primary analysis. In terms of those patients who had placebo, so 199 received the placebo, 6 did not receive the placebo, 3 withdrew from the study, 1 had choreo, 1 needed emergency tocolysis, and 1 had complete dilation at empty study. That being said, if you look at the bottom, you can see that all the women were analyzed by intent to treat. The primary outcome, the adverse perinatal outcome that includes perinatal death, chronic lung disease, etc. You can see the 24 mothers had an adverse perinatal outcome, and 28 in the placebo group. They went here by relative risk or hazard ratio, depending upon the table. And if it crosses 1, if the confidence interval crosses 1, then you can see that there's no difference between the two. So you can see in all of these numbers, in terms of the relative risk, the 95% confidence interval crosses the number 1. So the two groups happen to be similar in the adverse perinatal outcomes. In terms of the secondary outcomes, birth weights were very similar. Those who were in the NICU, you can see the percentage was 100 babies in the nifedipine group and 102 in the placebo group. Again, very, very similar. Those who required ventilation support, very similar. Those who were hospitalized at all were very similar. And just remember that the numbers were higher over here because of the multiple births. In terms of secondary outcome, the gestational age at delivery, 34 weeks in the nifedipine group, 34.2 weeks in the placebo group. How many patients got to a certain point? How many patients got to 32 weeks were very similar. Cumulatively speaking, how many patients got to 34 weeks? And how many patients got to 37 weeks and delivered by then? You can see that the numbers are all very, very similar in terms of prolongation of gestation. And Here again, another Kaplan-Meier curve. Kaplan-Meier curve. You can see that the proportion of number of pregnant patients. You can see the two lines almost parallel each other, or almost right on top of each other, I should have to say, between the nifedipine and the placebo group. The strength of this study is that there's clinically important endpoints because you're looking at what we were all interested in, which is neonatal outcome. This was the large nationwide study including 10 perinatal centers in the Netherlands, and included high-risk participants, although I don't know which study wouldn't. Only tocolytic maintenance was studied independent of initial tocolysis, and very few patients needed to receive additional tocolysis, which is lower than the previous studies. The limitations is that there was a lower than planned power for primary and secondary endpoints in the study designed due to a lower than anticipated control event rate. So they thought that the patients in the placebo group would have a 25% complication rate, and it was only 14%. So the question is, what was specific about this placebo group that they had such a low complication rate compared to what would have been expected? There was also inclusion of both singletons and multiples in the study, which we know can be a confounding factor in terms of interpreting the results. They didn't include the outcome there. They included the characteristics. They didn't. So you can see the vaginal bleeding at the entry of the study, how many had people at the entry study, but they didn't follow them throughout. This was just to make sure that the characteristics were the same. So, according to the data that I presented now, it seems that in terms of maintenance tocolysis by itself, it's questionable as to whether it helps. But what about drug reactions? Let's assume what's the risk of giving patients nifedipine if it doesn't help? Potentially doesn't help. So here's an abstract. This is a prospective cohort study. They had 28 hospitals in the Netherlands and Belgium. They had 1920 consecutive women treated with tocolysis for threatened preterm labor. The main outcome was maternal events leading to cessation of treatment, and the results were that an independent panel evaluated the reported adverse events without knowledge of the type of tocolytic used, and they decided whether the adverse event was related to the drug use. So 542 women took nifedipine only for acute tocolysis. The regimen was usually 2 to 4 doses of 10 mg sublingual nifedipine every 15 minutes, followed by 20 mg of a slow-release nifedipine every 4 hours. And with such a regimen, the plasma levels are likely to peak between 60 to 80 minutes after administration, and of course a concomitant fall in the blood pressure. So we're looking at the middle column over here. There was 442 singleton pregnancies, 162 with preterm rupture of membranes, 10 with a cardiac history. In terms of the serious maternal adverse events, there's dyspnea, 1 case of dyspnea, and 4 cases of hypotension. In terms of the mild adverse events, there's 3 of hypotension, 2 of tachycardia, and 1 of a headache. So if you put it all together, then out of the 542 women who took nifedipine only, then 5 had a serious adverse drug reaction, which is 0.9%, and 6 had a mild adverse drug reaction, which is 1.1%. And they considered severe hypotension being less than a systolic blood pressure of less than 100 or a greater than 20% drop compared with the baseline values. So that's most of our patients, actually. In 6 of the 7 cases, hypotension developed within 2 to 4 hours after the start of the tocolysis. And in this series, the relevance of this finding seems low, given the absence of obvious fetal compromise in the 542 women treated with nifedipine only. So even though they had the side effects, the babies did fine. So we have our practice bulletin, which is the management of preterm labor from June 2012. And just to look at the side effects of the calcium channel blocker, they say that it includes dizziness, flushing, hypotension, suppression of heart rate, contractility, less than ventricular systolic pressure. The contraindications include hypotension and preload-dependent cardiac lesions, such as aortic insufficiency. Based upon the study that I showed you, which was published afterwards, after the guidelines were published in May, it seemed that it's even less of an issue. Should tocolytics be used after therapy? Just to read the one line over here, when compared to with placebo, maintenance tocolysis with nifedipine does not appear to confer a reduction in preterm birth or improvement of neonatal outcomes. That being said, Cornell's group did a study in 2008 looking at contemporary practice patterns and beliefs regarding tocolysis among U.S. maternal-fetal medicine specialists. And they gave them hypothetical cases. One was a case of acute preterm labor, arrested preterm labor, repeated acute preterm labor, preterm prom without contractions, and preterm prom with contractions. And they looked at what would the MFMs recommend. So there was, you can see there was about 800 people who responded to this theoretical survey. In the acute preterm labor case, 96% would recommend a tocolytic. 2% would not recommend it, but if the patient desired it, would prescribe it. And 2% would not recommend it and wouldn't prescribe it if the patient wanted it in the first place. Too bad. The first line tocolytic, most people used was magnesium sulfate, but closely followed by nifedipine. If there was arrested preterm labor at 26 weeks with maintenance tocolysis, so 29% would recommend a tocolytic, so it's a big difference over here. 31% would not recommend it, but if the patient desired it, would prescribe it, and 41% would not recommend it, and if the patient desired it, would not prescribe a tocolytic. And here, the overwhelming majority of people who would prescribe the tocolytic would be nifedipine, by 79%. In terms of repeat acute preterm labor, so 56% would recommend the tocolytic, 20% would not recommend it, but if the patient desired it, would prescribe it, and 24% would not recommend it, and if the patient desired it, wouldn't prescribe it either. And here, the first line tocolytic would be, if it was for repeat preterm labor, would be magnesium by 41%, and closely followed by nifedipine at 37%. So, this is just some food for thought. I'm interested to hear what people's thoughts, complaints, or recommendations happen to be.
Long-term follow-up with
The last case went down to 6 months. The other ones didn't look at it.
The question is,
What I do? So this case who came in for the patient, I didn't give it. No.
what percentage of all of these patients are
I
think Calcium Blanca
don't know. We were actually discussing that. I don't know.
We've seen in blood pressure, we've seen it. Again, before coming here, that's the first thing I asked when I joined here, the fellow, why are you using Calcium Blanca? You never did use it. Maybe you can use it. That's what you would use it. But here it seems to work. It does seem to work. But long-term, I'll be effective with relapse after everything. I can feed my argument. What percentage possibly? I don't know.
Dr. Harris pointed out FFN to be the big one, because one of their main arguments about complaints about studies of preterm labor in the 90s was so many of the patients went to term labor, and so it was very hard to show the difference because it was hard to really identify a high-risk population. And in fact, that last study where 2/3 to 3/4 delivered before 37 weeks, I actually think they did identify those high-risk population. But FFN would seem to be potentially a good discriminator to build in as an inclusion criteria. If you really want to enrich for a high-risk population, and given that the outcome is usually delivered within 2 weeks, you could use that 2-week window, right, of oral therapy, and randomize women with symptoms who are asymptomatic and need positive FFN.
I would do it. I don't think it's positive FFN. I would the second period.
The numbers are, they did like 700 cases,
a liver study. They found that if you had a negative FFM, only 1% of them delivered. If you had a positive FFM, 16%. So totally what happened is 99% of the patients, overall, the whole group, regardless of the FFM or not, drink milk and they're blinded. The whole group, only 3% and then if you had a positive, if you had a negative FFM, it was 1%, and if it was positive FFM, it was 14%. So what happens is that you go from 96% to 99% negative predictability. It's a negative FFM. And you go from 96% to 84% with positive FFM. So you discriminate, but there's so much there that's clinical that we still know how effective it is. 96% not going to do it. But if you don't want to just let it doesn't make your population, that's one thing to do. I think the negative one excludes those who may go, which one may be part of that 30 to 50% of patients that deliver the tongue, regardless of what you do. And it could be because, like you said, they weren't true feature measure. Or if they weren't true feature measure, that's an acute episode. But all these studies, 30 to 50% of these patients who get control group or placebo, they all deliver it. And so you always wonder, are these patients labor to start? And so you need something to influence it. Should say it's nutrient or then you really get to higher risk. Because theoretically, they should all deliver a free form. Placebo.
Hard to believe it. Even with the very hard study, the amount of patients that completed less than 34 weeks, they looked good. I mean, I think that that was no smaller than the 20 in 7 studies. So I still wonder about this. They should be very good.
The new cervical one is 3/4 of the season, and that is statistically significant.
Right.
And then you look down at the thing, it's 15% difference.
What is not statistically?
And why wouldn't you have built, if you want to increase trends, why wouldn't you have done a separate randomization? So much of it. Yeah.
I just wanted to this is like 60. I'm basically good. Yeah, I don't understand all that.
You know, we can also, another reason why it's specific is that you don't have to take any judgment. Unless you don't perform studies. You know, they have to count the sales, et cetera, but I mean, that's how the real world is. That's how patients can take it. And the other thing is, you're, too much on the one. When you did the pharmacokinetic statements, because you had a half-life of 1.3 hours. And when they studied my cytokine levels in people with 33 to 58 months, because there's really hardly any more cytokine like that before. And all of these drugs therapies are PhD cells. So you wonder if there's the kind of pharmacokinetic company that is really to do cytokine life in the system. So that's one time. No, it's Q6. The first study was Q6.
One of them
But
was
anyway, you can look
went
at
down
that
to
anyway,
four.
but it was good up to 6. And the other point too, in terms of the hypotension and all those adverse effects, basically what to do there is you hydrate these patients, when they come in, not so much the snack, you hydrate them to expand the vascular space. So all of these smooth muscle relaxing, the smooth muscle relaxing, these are things that you don't do it, the therapies don't do it. I'm going to do it, but if your vascular space is expanded because of that hydrated, the effect on the pressures and stuff. And so that's really
Using we do these studies in our patients that are hospitalized after somebody before and look at that.
you could. I mean, that's
We could. I mean, that's one
and
thing.
then you should try starting with some clients and
Compliance
it's probably
there,
enrich the
then
population. Okay. Then you try to restrict it to, include the community separate studies. I mean, you could. But it's a long undertaking. To do that.
Thank you.